Yeah, thank you so much for the very generous introduction and really excited to be here today. I wish I was in Vancouver in person, but still had some clinical effort that I have to do later this week. But really wanted to share some of my perspectives as well as kind of the opportunity to describe, I think, a framework that you guys and the previous speakers have already so eloquently described. The broad outline of the talk is that I'll talk a little bit my perspective. You'll recognize that I'll talk a little about the framework of how to think about some of the challenges with kind of causal inference, particularly for imaging, and examples and suggestions on how I approach what is both realistic and unrealistic expectations for AI or ML. Broadly speaking, as I've mentioned, I'm a cardiologist. So while I've studied statistics in undergrad, it's been more than 10 years since I've actually done any kind of formal math or proofs. So for the bulk of this talk or the rest of the talk, there will be no kind of, I would say there will be no formulas. It'll be a high level evaluation of the evidence and how to frame when and how to design AI models and what are realistic and unrealistic expectations for the AI models, as well as lending from some of the, I would say, the focuses of medical training to ascertain whether it's a reasonable or appropriate kind of intervention. I would say that during medical school, there's a lot of training on why or how to evaluate case control studies, how to and why we do randomized clinical trials, and many of these ways where we actually truly prospectively study intervention that is grounded in really the ideas of this kind of workshop, which is that causal inference is something we strive for, but with some retrospective data, often it's hard to truly achieve. So before I talk about AI, I usually like to start a lot of my talks with this picture. It really, for me, reinforces the idea that a picture is worth 1,000 words. This is a picture that's published in the New England Journal now more than 10 years ago. And instead of someone with disease, is actually simply a truck driver. Over maybe 20, 30, 40 years of driving a truck, maybe the same routes day in, day out, you can see that there's asymmetric sun exposure. And you can see that there's asymmetric phenotyping based on that exposure. His skin is much more wrinkled on the right-hand side as opposed to the left-hand side. And this is what I would describe is the value and the beauty of imaging, where there's some relationship between the environment, maybe the sun exposure, inheritance, the fact that he's Caucasian and higher risk for skin cancer, creates a phenotype, which is the presentation of how that environmental insult or disease manifests, that we interrogate with imaging. And I'll use imaging broadly. This is a visual picture, but similarly, this is why we get X-rays, why we do MRIs, why we get CTs. And ultimately, at the end of the day, as patients, we might not care about what it looks like, but the thing or the reason why it's so valuable is because there's a association or there's a relationship with clinical outcomes. And as a cardiologist, we often have many metrics that we know that have been rationally or human evaluated. Things like the ejection fraction, the assessment of function of the heart, things like the coronary calcium, which is assess of how much artery disease and how much calcium there is in the heart arteries, and then SCAR or delayed gadolinium enhancement MRI. Those are all human features that have been derived. And even in this setting, these are simply risk factors. Meaning that there might not be a direct causal relationship with any of these metrics, but because they have such a strong association of the imaging finding to the clinical outcomes, we find that to be very meaningful in the clinical setting and really use that to guide how we make decisions, both in diagnosis as well as in treatment. But what's really exciting about AI is that this is a new, unbiased way to interrogate imaging features. While humans have recognized some features, and obviously these are important features, there might be much more remaining. And I show this picture of an iceberg where maybe 10% of what's recognized by imaging right now is actually directly related to how we treat and diagnose disease, but there's additional value. And I think that that's both the opportunity as well as the challenge with ML in the medical space, because we're soon getting up to the point where we are actually dealing with models that predict tasks or predict diagnoses that humans cannot do. But in that setting, how do we benchmark? How do we evaluate whether that's realistic or unrealistic? And how do we actually ultimately decide, is it causal enough or is it meaningful enough to actually guide treatment? So I think that the previous speakers already have described it really well. So the general framework I will say is that, obviously in any kind of supervised ML task, it's A predicts B. And we use this in many contexts. And in the MICCAI framework, it's in medical image goes to medical diagnosis. So I know that actually both of the previous speakers have talked about chest x-rays. So I'll talk about chest x-rays as well. For example, a common task is diagnosing of pneumothorax or pneumonia or many other things that we can actually truly detect on the chest x-ray. This is a human radiologist readable task, meaning that we know that in the input information, both the information is necessary and sufficient, where you can definitively say yes or no to that label based on the image. And I actually show the representative choice of a pneumothorax, which is essentially air in the space between the lung and the chest wall. And this is something that actually is a representative image here, where you can see on the left-hand side, on the right lung, there is actually less lung markings, so suggestive air here. The ultimate challenge, as I've described, is that we're now getting to the place where we can actually train many models for many different tasks. And many of these tasks actually are not human recognizable or are not routinely obtained by radiologists to ascertain from that input image. Questions like age, that's something that I think maybe we have some intuition of who's an older or younger person, but probably cannot predict very well from the imaging. Surgical or procedural risk is similarly, if you see someone who might look relatively obese or might have a lot of medical instrumentation, that might be a higher risk patient. But generally, radiologists aren't able to assess the surgical risk based off the images. And as well as kind of race, which is a really complicated situation, but recognizing, and I'll describe a little bit more in the subsequent slides, but that's often something that we don't usually associate with chest x-rays that don't actually have a visual impression or kind of a superficial view in terms of kind of racial demographics. So in this setting, when there's so much information in the chest x-ray, obviously this is the bottom of the iceberg, we do know there's a lot that humans don't recognize. At the same time, we have a lot of many tasks that maybe seem to almost defy expectation. How do we evaluate this? Or what is a framework that we can use to really assess whether we believe or whether this is a really good relationship or a relatively weak relationship? So I'll propose 3 ideas, as well as kind of use some of the context that I have as a clinician to describe how I approach them. But ultimately, I think that this presentation is actually not grounded in very many numbers, but it's mostly to highlight how I approach whether I think this is actually a realistic or unrealistic goal or performance. So the first task or the first framework, which I think is uniformly true, is that when at all possible, use domain knowledge to contextualize whether you think that this information is real or not. One example I give is that there have been papers published where many different inputs have been trained to label or to classify very unrelated outputs. Kind of one paper that was published now, it looks like I think almost 2 years ago now, is the development of using EKGs, so heart electrical waveforms, to predict liver disease, cirrhosis. And this is something that I think the authors have published has a very high AUC, in that they were in their control and in the distinguishing between their cases and controls. They actually had very high performance. You'll notice that in their paper, they mentioned that the patients were age and sex matched so that they're hopefully removing some of the confounders. But ultimately, the recognition is that maybe there is something different about patients with liver disease, cirrhosis, versus patients that don't have liver disease. And that is an opportunity for shortcuts. The challenge with a lot of, I think, medical or even ML literature is that we might not have access to all the demographic information or all the comorbid definitions. Maybe people with cirrhosis have more heart disease as well, and that's what's being picked up by this heart diagnostic. Or maybe people with cirrhosis are older, and that's what's being picked up. But ultimately, that's actually very hard to interrogate if you don't have a comprehensive view of the situation or of the input data, or specifically the training data. One rational idea, and one thing that, as I read this paper, I was thinking is that there might be systemic presentations that are readily recognizable that actually strongly associate with cirrhosis, but that might be the shortcut that some of these models are actually interrogating. One example is the idea of ascites. So when one has end-stage liver disease, in addition to the liver being dysfunctional, some of the downstream effects are actually that your belly gets more swollen, that you actually you retain more fluid. This is something that is actually readily visible, and is something that actually dramatically changes a lot of the diagnostic tests that one gets. Meaning that in addition to the body habits or how one looks, there's actually a lot more fluid all over the body. And that's something that can be picked up by the EKG or the electrical waveforms, because as you have more distance between the EKG leads or the electrical leads and the heart, there's more impedance, and that results in lower amplitudes of the waveforms. So for us to test this hypothesis, I use data at Cedars-Sinai where I work, and we first trained a model to go from EKG with age and sex matched controls, predict cirrhosis. And it performed reasonably well. This is the green arrow in the middle, which had an AUC of 0.76. It's not necessarily as high as what's published in the literature, but to kind of our best approaches after doing a fair amount of hyperparameter searching, that's something we can obtain. At the same time, instead of using a label of cirrhosis, we actually subsequently trained a model, or a different model, where we use the EKGs to predict ascites, so that we wanted to see if EKGs can actually identify ascites. That actually similarly performed reasonably well, probably within a confidence interval of cirrhosis, which had an AUC of 0.79. So this is something that we do recognize that, at least from a clinical perspective, maybe a little bit more attainable, or a little bit more recognizable in terms of the features that can be recognized with ascites. The final piece that we wanted to see if this was truly shortcut, and this is still only circumstantial evidence, was that with the trained ascites model, we then went back to the test split of the cirrhosis dataset and see if we can actually detect cirrhosis. And that actually did just as well, if not slightly better, in actually detecting cirrhosis. So with a model that's trained to detect ascites on a completely different data set that didn't have any patient leak in the test fold, we actually were able to get an AUC of 0.78 to ultimately define cirrhosis from the EKGs. This, to me, felt like very strong evidence that potentially there is a shortcut in this circumstance. Potentially, this is not generalizable to every ML approach or ML model, but is recognizing some of the clinical features that might be relevant. But conversely, we actually then tested the performance of the cirrhosis EKG model on patients that we knew had cirrhosis, but did not have ascites. So this subset of the test population, we actually saw had a substantial deterioration in the model performance, where in the subset of patients in the test split that actually did not have ascites, the performance of the model was an AUC of 0.68. With this, both kind of a positive example from a different label versus the negative performance in patients that did not have that collinear label, to me suggests that there's really strong evidence of a shortcut learning in this approach. But the main challenge, and the thing I want to highlight, is how do we generalize this approach? Or how do we think about this, especially when there are so many different tests that are being predicted and being published? And similarly, how do we think about it when maybe we don't have domain knowledge? I think that, I particularly chose an example where I'm a cardiologist. I look at these EKGs all the time, so I might have a little bit more intuition. But is there a broader framework that we can use to assess causality or opportunities for a shortcut in our data set? So the corollary, I would say, is that kind of this is something that in my group we heavily emphasize, and I think that this is something that is true in broader ML, even outside of medicine as well, which is really look at the data. Andrei Karpathy, who I think is relatively famous, kind of both at OpenAI, was at Tesla, had a really great series of blog posts when he was a PhD student at Stanford. But I think thoughts really resonate with me, which is the idea that the first step to training a neural net is not to touch any neural net code at all, but begin by thoroughly inspecting your data. So I generated a couple of images using kind of Midjourney, but the idea is that let's say that you have a case and a control or a labeled set of data. If you look at it and you're able to visualize the difference or distinguish kind of ideas or concepts, that's probably a good way to make sure that that's actually sane and real. Like one example of I would say that kind of like, let's say that you wanted to classify people based on their pictures on East Coast and West Coast. If you simply chose or cherry picked kind of cases of the East Coast from Wall Street versus I would say the West Coast from a baseball game, that might give you a very skewed data set. While nominally true of East Coast versus West Coast, that might create a model that generalizes relatively poorly. The challenge with the broader ML literature is that this is a circumstance that actually ultimately happens very frequently because there's a lack of data. When we think about MIMIC, which I think that many of the previous speakers have already talked about, that's actually a data set of chest x-rays and information from people in the ICU. That's not necessarily directly reflective or representative of the general, I would say, worldwide population, or even a population of people that are less sick. And I think that that actually creates a lot of biases in terms of what can and cannot be generalized from in such a data set. And during medical school, one way that we evaluate information is there internal or external ability? And I think that that's extremely true for a lot of ML models. For example, like in this toy example, maybe you can actually recognize that actually wearing a hat maybe would be learned by a model much more easily than actually a task that's complex and important or challenging, such as East Coast versus West Coast. When you directly interrogate the data and we directly actually look at it, that might be an opportunity for you to evaluate what are shortcuts that you as a human can actually evaluate and recognize, and an opportunity to actually debias your model if you have sufficient data. And at least in my group, oftentimes I recognize that there's tremendous hesitation from the more technical members of the team because they feel like they don't necessarily know enough medicine to really look at the data. But I would argue that's almost the opposite case, that if you're coming from an unbiased approach where you don't need medical domain knowledge, looking at the information is much more valuable because it gives you a sense of what are ways that actually there's much more bias that might not be recognized or might be missed by someone who's routinely looking at these images or these films or these videos. A really famous paper that came out last year is this paper using chest x-rays as well as CT and a variety of other imaging modalities, which was suggested that in this data set, most imaging data is actually able to detect race. And I think that that's actually an area that we've published, and I want to share kind of some of our perspective, where I think that that's a little bit of a challenging interpretation to have. And it's an area where I think that really I frame with the framework of some of the 3 tips of how to evaluate whether this is truly a causal relationship or not a causal relationship in ascertaining whether these models are actually detecting something truly race determining. For going back to the example of looking at the data, the authors of this paper actually did a series of very elegant experiments. And actually what they did was that they actually tried to denoise or kind of reduce information in the data sets using both high and low pass filters. And you can see they actually were saying that even at a very high threshold, you can actually still detect race on seemingly relatively low information images. So that from the way that they constructed their data sets, actually having a high pass filter, even up to with a really high pass filter where you're losing most of the information, such as like a high pass filter at 100 diameter or a low pass filter at 5, these are still sufficient input to actually predict race in their data sets. And I would actually say that as a human, if you were to show me a bunch of images like this, I would not be able to. But my perspective on this data is that actually This makes me more concerned that there's data leak, that there's leak whether between splits or imbalance across essentially cohorts or data sets, than that there is actually a truly meaningful signal in the actual medical imaging itself. And that gets to essentially my second point, which is beware of unrealistic expectations. One of my most common heuristics when I evaluate a manuscript is I generally actually believe a paper less when they report an AUC of 0.99 or have a DICE score of 0.99 or something that's incredibly high. And the reason I say that is that to err is to be human. If you look at any medical task, or even taking outside of ML, if you went to two different doctors, it's not unreasonable that you'll get two different opinions. And this might be, you're saying that this might be a really complex case or a really complex scenario, but we recognize this even in the simplest of tasks. Two examples, since I work with cardiac imaging, is the idea of measuring wall thickness and diameters of the heart. You'd imagine that's actually a linear measurement done thousands of times a day. Maybe it should be some of the easiest measurements that one can measure because it doesn't require multiple frames, doesn't require multiple videos, isn't a holistic assessment. Yet even in this simple assessment perspective, there's tremendous intra-observer variability. And this is true both in all forms of imaging, whether it's MRI or X-ray or CT. And I think that that's an area where I would say that the reason you should be cautious for a really high AUC is that you are entirely upper bounded based on human performance. If two reasonable humans can actually label the data in slightly different ways, it feels relatively unlikely that you're able to always perform the same way as human A rather than human B. And that the opportunities, or if your model is actually having a really, really high AUC, that speaks more to the split or more to essentially kind of, I would say, overfitting, rather than actually having a direct representation of what's truly impactful or meaningful in the data. And when it comes to race, one example I give is that actually in the United Kingdom, they've actually evaluated how likely people are to report the same race across different data sets. So the UK government actually linked a couple of data sets. I think some are related to healthcare data, some are related to maybe tax data, other stuff like that. But as you link the same individuals, actually people still are discordant between how they represented their race. And I say that this doesn't necessarily mean that their race isn't real or stuff like that, but it's really showing that like if there is noisy labels, it seems like it's very hard to really hit AUC of 0.99. The noise at the top is really the upper bound of what we can expect. And this is even beyond some of the other challenges one has with the labels that we use in terms of kind of race being a social construct, meaning different things at different locations, or being, you know, Asian is slightly different from being in the US versus being in the UK versus elsewhere. And I think that that's ultimately an area where I think it's a little bit more challenging to produce models where you go from medical imaging to predict some of these tasks. The third question, or the third perspective that I have for this kind of evaluation of AI models, is to evaluate the impact of balancing covariates. And I think that the two examples that I've shown before, as well as what the previous speakers have shown, is that actually the lack of balance of covariates might be enough to actually shortcut the model. And again, the main challenge is that with a lot of medical imaging data sets, by nature of the lack of privacy preserving, such that you don't have all the information on what covariates they have, or the lack of relative scale or size, makes it very challenging if you're not in a healthcare environment to recognize where there's biases and where there's imbalance. So last year we published this paper, which I worked as a cardiologist with cardiac ultrasounds, but we wanted to reproduce some of the work published in Lancet Digital Health regarding race. So using cardiac ultrasounds, we predicted a couple of demographic features. First, using Stanford ultrasounds, we predicted whether there's male or female in the Stanford cohort, which had an AUC of 0.93. Did external validation where there's some deterioration, but still performed pretty well. At the same time, we also predicted race in the Stanford cohort, not as high as I think what's previously published in the literature, but similarly, there is clearly signal. And then we also show that this signal externally validates. And similarly for age, we're able to predict age from the cohorts, with an MAE between 7 and 9. In this setting, this is a unbalanced cohort, with is just using close to 100,000 echocardiograms from Stanford. And because I work in the healthcare environment itself, and this is not public data, I actually do have a variety of ancillary comorbid information regarding all of the demographics. And one key example I would show is that if you look at the white patients versus the Black patients, they're in almost every measurable feature, they are different. African Americans actually had less atrial fibrillation, more heart failure, more hypertension, more diabetes, more stroke. If you go down the list of all the comorbid information, this is something that you don't pick up from the cardiac ultrasounds, but directly relate to potential disease states, where maybe in the US there is bias in terms of access to care, such that if you use a healthcare imaging data set, patients who have less access might actually already have be sicker or have essentially more disease at the time of imaging. And those are signals that directly can be picked up, but maybe not necessarily a direct reflection of race. So because there's all these I would say, maybe potential confounders, potential shortcuts, one experiment we tried to do was actually balance all recognizable or a couple of recognizable features and see if the balance or the bias actually impacts the performance of a model. So this is a relatively toy example, but is in the race prediction task. If you balance the information or the cases and the controls by sex versus if you gradually unbalance them, does that actually change the AUC of the performance of the model? Such that example for the bias equals 0.5 on the left-hand side, that means that every Black patient also was female and every white patient was male. In that setting, the AUC was, that's a bias of 1. In that setting, the AUC is 0.84. But then if you unbias the data sets, where both in the Black as well as the white populations, there's 50-50 split of males and females, then we actually get an AUC of 0.56. There's really a concern for shortcutting, whereas we see that as we adjust how much bias there is, there's actually a dramatic difference in terms of the performance of the model, where you can see that the more biased the model, the higher the performance, suggesting that a lot of the value of the prediction task actually comes from that confounder. And we also did the ancillary comparison, which we predicted sex, male or female, and then we actually skewed data based on different cohorts of proportion of Black and white patients. And you can see that to the first approximation, regardless what is the true split of the training data in terms of race, actually the sex prediction was roughly the same. To me, this suggests that most of the explanatory power actually results in the sex prediction task as opposed to the race prediction. And this is an area where you guys can read a little bit more. This was published last year, but this is we also externally validated with CEDAR's data as well, just to show that this is actually true in many different ways to split the data, even when there is external validation. Some of the intrinsic societal biases might just be equally true at different sites. Maybe African Americans actually have less access to healthcare at many places so that they can recreate the same bias, but doesn't necessarily mean that the medical imaging actually has that causal relationship that you're able to truly detect race. And I would say that the final piece, I'll leave it here, is that what you guys are discussing today is incredibly important because this is actually true even in FDA cleared devices. Meaning that I think that for regulated devices, obviously we have a higher bar and we should be much more thoughtful, and we should evaluate whether the model is truly detecting a disease or identifying a diagnosis as such. But this is such a nuanced question that I think oftentimes the FDA hasn't fully recognized this, and that because you can generate arbitrarily good performances in internal test sets and maybe sometimes in external test sets, some of the FDA cleared products actually have a similar challenge. And here, this all fall back on domain knowledge and really only talk about cardiology, which is there's two examples I like to show. One of which is that there's a recently cleared product for detection of HCM. And as well, there's already been multiple papers published on detection of HCM or hypertrophic cardiomyopathy from the EKGs. But the key intermediate is that hypertrophic cardiomyopathy means that you have thick heart muscles, or LVH, left ventricular hypertrophy. But hypertrophic cardiomyopathy is only one of many reasons why you have thick heart muscle. You can have thick heart muscle if you have valve disease, if you have uncontrolled high blood pressure for many years, or kidney disease, or a variety of reasons. But because the cases and controls are only age and sex matched, this lack of matching in terms of wall thickness actually results in the ability to shortcut and detect features that are readily recognizable. So on the EKG, it's readily recognizable how thick the heart muscle is. That actually is not directly related to the disease of HCM, but might be actually a shortcut finding. And I think that in some of the papers, you will actually see this is truly an example, meaning that the septum, this is actually the measurement for true positives, very thick, which is higher than the false positives. So you can see that it's skewed towards looking at high or thick heart muscles. And for negatives, the negatives are the patients with HCM, but actually didn't have very thick heart muscle. And the false negatives are the ones that similarly actually are thicker, but less, but essentially maybe not thick enough. Ultimately, you can see that there's a direct relationship with wall thickness. And this is something that I think people, maybe even in regulated settings, we have to be very careful with the models we use, because there's a lot of concern that this actually might not be true. And again, going back to the idea is that there was a recently published paper, which is another FDA cleared product, which actually in the discussion was saying that another key limitation is that in the training cohort, matching for age was not possible. Patients with HFpEF were older. So you can see that kind of in terms of the case, in terms of the age for cases, they were older than controls, such that for such a device, there's actually a really strong concern that there is actually prediction of age as being confounding with a diagnosis of HFpEF. And you can see that similarly, the cases that are being predicted correctly are older than the cases that are predicted incorrectly. And on the opposite relationship, the controls that are predicted incorrectly are older than the cases or the controls that are predicted correctly, such that there seems to be a really strong relationship with the model output versus what is actually kind of correct or not correct in terms of the model output. All right, well, I wanted to say thanks for the opportunity to chat with you guys. I hope that this is a little bit perspective on how I approach this from a more of a clinical lens. But I think ultimately what you guys are discussing and the approaches are extremely important, because ultimately at the end of the day, we really care about causal relationships. And we're really hoping that our ML models actually provide a lot of information that can be generalizable across many places. And happy to take any questions, and thanks for your time.